all about co-designing for us here in Australia, because there's a history of, here you go, you mob, we've made this for you, you go run it. And then, government and white society wonder why it never works. It's because we've never had any involvement in actual developing something. So we now have a saying that says, nothing for us without us. So there's a big push on, co-designing and, connecting with community, and our programs coming from grassroots.
That was Eliza Munro, Indigenous palliative care educator from Australia. On this episode, we talk with Eliza and Kelly Clark, who are both palliative care educators and consultants on IPEPA. IPEPA stands for Indigenous Program of Experience in the Palliative Approach, which is a grassroots approach to breaking down barriers to palliative care for Aboriginal and Torres Strait Islander peoples across Australia. We chat about the important work they are doing with IPEPA, the barriers Indigenous people face accessing palliative care, and what they are hopeful for in the future.
Hi, I'm Xian Xiao.
And I'm Sammy Winemaker. We talk to people who have information and tips on how to unlock a better illness experience.
The waiting room revolution starts right now.
So, Kelly, Eliza, welcome to the podcast.
Thank you.
Thank you.
I'd love to start, if maybe I'll ask Kelly first, if you could introduce yourself and your role.
Okay, so I'm Kelly Clark, and I am part of an Australian government palliative care project. I work and cover the whole of the Northern Territory down under in Australia, and we deliver palliative care work, education. So we try to create experience in the palliative care either through workshops that happen with professionals, mainstream healthcare professionals and aged care, or we get them to come into a specialist palliative care service and experience it firsthand. So yeah, that's what I do across the whole of the Northern Territory.
And how about you, Eliza?
So thank you. So Eliza Munro, I'm a Gamilaroi woman from the Gamilaroi Nation, which is a second largest country of New South Wales, which is on the east coast of Australia. I was born on country, but grew up on Wonnarua country down a bit further south, and call Maitland home. So I'm a Maitland girl at heart, but country is Gamilaroi. I'm a mum of five, deliver palliative, sorry business consultant, which is death and dying term for Australia, for our Aboriginal communities. I deliver palliative care education and training across the state of Queensland, and currently consulting for IPEPA Queensland, which is a federally funded program, along with Kelly.
Amazing. And Kelly, can you tell me a bit about your family? I don't want you to miss the chance to share about where you're from.
Yes, excellent. So I was born in Derby. However, my family ties are back to Kununurra. So I'm a Mirrorong Gazarong lady from over there. And my grandmother grew up on an Aboriginal mission, but my family, my great-grandfather actually really valued education and moved his family to town. And but I was born in Derby, have a wide network of family all over Australia, but am currently living and working in Larrakia country, which is Darwin, or Garramilla, as they call it here. And but yeah, there's so many Aboriginal and Aboriginal nations across the NT. So going to different country all the time and learning from them. Yeah.
So you both work for IPEPA, and it would be great if you could, maybe I'll start with Kelly, if you can tell us what is IPEPA and, how did that come to be?
Yep. So I think it was about 16 years after the PEPA, which is Program of Experience in the Palliative Approach program, was started in Australia. They branched off into an Indigenous program of experience in the palliative approach. And so these are, targeted learning pathways the first workshop is a palliative approach to care for Aboriginal and Torres Strait Islanders. So that's more aimed at the mainstream so that they get an understanding of some of the cultural complexities and ways to approach palliative conversations with First Nation families. And then it has a second workshop, which is a palliative approach to care for First Nation health professionals. Um, and that changes wherever you deliver the workshop, because you have to think about the context that they're in and honour the knowledge they bring to the table. And then there's a few other things that have come out recently. There's a Seasons for Healing Social and Emotional Wellbeing workshop, and there's a palliative care education toolkit, which is about 10 to 12 learning hours, which can be done online or through a workbook.
So, Eliza, I'd love to hear why you think the I in IPEPA is so important. I mean, what is it about an Indigenous specific focus that is important and unique?
So the importance of if we're focusing on this, if you can say this, the separate component of IPEPA, it was important for health workers to have a culturally safe space to learn about, death and dying, what we call sad news and sorry business in Australia, to learn about the what is of palliative care and have those sensitive conversations in a culturally safe space. Sometimes when we have non-Indigenous peoples in the room, it can be challenging to yarn and to be honest and vulnerable in those conversations and to share freely. The beauty of the health workers, which we call in Australia Aboriginal and Torres Strait Islander health workers and practitioners, to be in the same room together is also that networking and that support. So, but particularly when we've got complicated or compounded grief in Australia, where we have multiple sorry businesses in community, it can be such a sensitive topic to yarn about in general, which makes it challenging to have, to do palliative care education. So it was important in that sense to separate and have the IPEPA component of PEPA. The other and the other component is obviously the culturally safe and responsive palliative and end-of-life care to train or to upskill the cultural capability of our non-Indigenous health workforce to care for our mob safely in this space. And it was important because we can't do it would be rude of us or to teach cultural content in a room full of Aboriginal and Torres Strait Islander health workers, because we live and breathe culture on a daily basis. And it would be, I think I've recently heard a saying, selling, ice to the Eskimos. So it'd be similar to that. So it was important to have that separation.
I agree with Eliza, and also, palliative care supports people in their really hard times with some of the most difficult choices in their lives. So to approach these conversations, I agree, just having those discussions about how to do it sensitively to people's culture. Because if our mainstream health providers aren't able to communicate safely, well, people aren't going to access palliative care. And in fact, what we find a lot in communities is people have never heard of the word palliative. It's not in their vocabulary. And also, there's also a lot of negative, I guess, beliefs about what it does do, because there seems to be an idea that, you get given this medicine and then you'll pass away nicely, sort of thing. So there's so many different things to talk about and to unblock and work out how to bring it up, so we don't make any previous experiences of healthcare which may have been racist, it may have been traumatic, and try to make it so that everyone understands and ready to discuss palliative care and has that right to choose whether they want to access it or not.
What are some of the reactions from non-Indigenous healthcare providers who take your training and then use them? I mean, what are some of the reactions that they have?
In all honesty, it depends on the individual. There's a lot of cultural stereotyping in any culture. And likewise, I imagine, like Canada, we have a lot of, a lot of different countries, a lot of different nations within our communities, and there's so much diversity. And as soon as a non-Indigenous person hears one, protocol surrounding business, then they run with that and apply it to all Aboriginal people. So there's a lot of cultural stereotyping, and unconscious bias that people come in with in terms of the culturally safe and responsive palliative care. And then you have the other side of that, where it may be a negative unconscious bias, or it may be the sort of savior type mentality. So that you've got to be careful in how that education and how you deliver the education itself. But there's a lot of positivity that comes from that. But the joy I see is when people take the aha moment, and I think it's all about clear communication too. We have a fear of offending as well, where people are, ashamed in a sense to actually ask questions because they feel like embarrassed, because they don't want to actually think they should not be asking certain questions when it comes to cultural elements. Yes, we aren't going to share sacred cultural information, but any information that's going to improve that relationship or that cultural understanding of how to care for Aboriginal and Torres Strait Islander peoples, then that is going to, break down some of those sort of barriers to accessing. So that's rewarding in a sense.
So
Love
yeah,
it,
Kelly,
Eliza.
have you been surprised at some of the reactions or the learnings that people have?
Yeah. So I guess, just starting at the start in healthcare, you've probably heard me say it at the conference that even just starting with this concept that the government is always going to work in your best interest and has no say over your everyday life, when that's not the case
Hmm.
for many Aboriginal families and our elders who have gone through being removed from their family and then returned. That only stopped in the 70s in Australia, and there's still so many children being taken. But I guess so just understanding that a hospital is not something that's viewed as something that's somewhere you go to get healed and a safe space, you know, um, it's somewhere that maybe your family went to, never came back, or came back and had, talks about this really white, sterile environment that was freezingly air conditioned. And, all these people were really angry at you, and yeah, so just starting with, you have to be open to learn and be in two-way conversations and curious, and thinking about what your body language is saying and your tone of voice, and just, challenging some of, you know, pardon me, some of your beliefs that, you've got the right way and people just need to get on board.
Hmm.
Which, and sometimes when you see it land with people, it's very rewarding. And I think in the Northern Territory, we have over 100 different, Aboriginal languages and peoples and dialects. And so we actually represent 70% of the NT Health patient caseload, just by the nature of how vibrant and alive the culture is. And we make up 30% of the population. So it's very relevant to people, and it's really lovely when you get people saying, "Come back now. We've got a new group of staff and sit down," because I think that's where the power is, just sitting around a table and getting out of that, cure all, deliver health, you know, fast paced environment, and talking about some of this stuff is where the power is. Yeah.
Hmm. I'm curious. I was fascinated to learn that in many First Nations communities in Canada, they don't have a word for palliative care. And you said the same thing earlier, speaking about Aboriginal and Torres Strait Islander communities. Um, so what words do you use to talk about this difficult topic?
nationally, if you say sorry business,
Mm-hmm.
among Aboriginal and Torres Strait Islander people, they will understand that it is talking about this time of life where either passing away is coming or has happened. And so usually when you hear that word, you would say close a community, you wouldn't engage with that family, you give them space. If you were working in community. So, some people, everyone's an individual, will choose not to discuss anything to do with it. In fact, from my family and from what I've learned while working in this industry, is it used to be a time when traditionally an elder would leave the camp and go and set aside under a special tree, and it's a beautiful return because that's often where you were born.
Mm.
And so I'm not saying that you would return to your tree of birth, even though I know amongst my family members, people knew where it was and it was shared and pointed out, this is where the tree grandpa was born under. But, so you just have, you have to just be sensitive about it and see what people are willing to engage on and share on in that part of their life journey. But I've said it before, I get the feeling that a lot of people will just unplug from healthcare. And I know I've said it about myself. I want to go home to community and just see it out. If I ever had something like cancer or things like that, and I certainly hear that along in work as well. This that's a time to return to country,
Mm-hmm.
to connect back.
Mm-hmm.
Yep. So from my understanding, there is no interpretation of palliative care like palliative word itself. Some communities will use supportive care or comfort care. I myself personally like to use the returning to spirit journey, bringing in that spiritual aspect and reframing it for communities, because palliative care is something that we've done for generations and generations. Palliative is a white man's word, sorry, and that is, but naming something that we've always done. And so reframing what that is, because we tend to care for our own in community. It wasn't until Christianity came into Australia that I believe, because we believe in a life, death, life cynical approach. So returning to spirit, returning to dreaming, whatever that spiritual belief is for that community. But the overarching is that there is life after death. So Christianity bring in a aspect of fear, I believe, around, heaven and hell, that concept. And it is something that I've heard in, generally in community as well. So there are a lot of communities that are still follow Christianity, and there's a lot that are very much against it because of the history and what's happened there. But returning to spirit journey is my favorite, and is how I reframe the actual word itself. I'm also supportive of palliative care word itself, because at the end of the day, the word itself is not going anywhere. And if we're not educating community on what the actual meaning is, then we're playing into that misunderstanding. We're not supporting, the upskilling of community and our Aboriginal and Torres Strait Islander health professionals. If we continue, if we were to not sort of use and educate around the word itself. So I tend to returning to spirit journey, but are still supportive of education around the actual palliative care word itself.
Yeah, no, I think language is so important and words are so important. And you both talked about that. So thank you. You mentioned a term that I just wanted to understand you both talked about yarning. What is yarning for someone who's not from Australia? That's a new term for me.
Yarning is a term, would you say colloquial term used? So I guess it's more about sharing a conversation without. So I guess what we do is we yarn about non-medical things. We establish rapport. One of the usual things Aboriginal and Torres Strait Islander people will say to each other when they meet is, "Where are you from?"
Mm-hmm.
To create connections, and usually someone knows someone or has been to someone's country, or your third cousin's wife is from that way, and that's how you connect. So we try to teach people to have these connecting conversations before getting into any of the medical health discussion. So yeah, when we say yarning, it's just an open, friendly chat.
Okay. So maybe in North America we might say small talk. I don't know if
Yes,
kind of like that, but it's not just, about the weather. It's more personal, a little bit more about trying to understand the whole person, I guess, a little bit.
agreed. So you know, when you go to mainstream healthcare, I've been to many doctors where you feel like you're sitting there and it's your Medicare number that is sitting there with the doctor, not you as a person. There's no personal exchange or um, interest.
Yeah.
You're there, you're sitting there as your disease or your health complaint.
Yeah.
So I guess we just try to teach people in our education, just spend a few moments to acknowledge the person in front of you, create some sort of connection, have a yarn, and that goes a long way to being culturally appropriate, you know, because I guess a lot of different services and approaches out there, throughout history with Aboriginal and Torres Strait Islander people, is you were in missions, government workers used to come in and take away, you know, um, the fair-skinned children. They used to check on your homes and come past, and so there's this distrust there that
Hmm.
people aren't interested in, or are racist. So you've got to overcome that hurdle before people will really open up to you about and share, their decisions. Um, yeah, their
So,
reasons for their decisions, which will
hmm
help your healthcare, especially when it comes to palliative,
yeah.
and it is dealing with families and choices and high
Yeah.
emotions. Mm.
Yeah, but in Canada, we have this colonialist history where we had these residential schools where children were taken from homes and put into these residential schools that were run by, nuns and priests, and their culture was taken. And I'm not sure that everyone who's listening might be aware of that it was a very similar thing that happened in Australia.
Yeah, so I do likewise with Canada and America. A lot of Australia's past policies were based on following what was happening in the States and Canada, and unfortunately, Australians, Indigenous people, also were removed from families. The idea around that was assimilation. So removing, as Kelly mentioned before, removing the fair-skinned children to assimilate into white society, and the concept of breeding the black out. So in Australia, we, as Aboriginal and Torres Strait Islander peoples, call ourselves black. So that's the terminology that we use here. So to breed the black out of the individual, and therefore loss of cultural, there was no cultural aspects, and children were removed and placed into homes. Traumatic things happened in those homes. A lot of sad stories, which people are still trying to find their way home today, as well as find their identity, unfortunately. And Kelly spoke about, the walking the two lines. Some of our stolen generations are stuck in the two worlds because they don't feel they belong. They're not accepted in our, sometimes not accepted in our Aboriginal communities because they're not, haven't grown up, and they don't carry the cultural, or they're not accepted, and they're not accepted by the white society because they are clearly Aboriginal, or Torres Strait. So there's that element of being not accepted, so therefore loss of identity, and you can only imagine the trauma that person would carry, losing the sense of belonging and everything else that comes with that. So, the grief and loss that we carry from that is enormous. And when we talk about intergenerational trauma, when stolen generations grow up and are not able to, culturally have that information to pass down to their children and their children's children, then there's this loss of culture. But there's also the negative element of, the grief and loss that they carry, and what happens when we're carrying that, and how do we numb those feelings, those not so nice feelings, and the learnt behavior that's passed down. So there's a lot of trauma that's still carried within our communities today that we're slowly trying to heal from.
Yeah,
Thank
thank
you.
you. Yeah, thank you. I think that's just important context for us. Kelly, were you going to say something? Go ahead.
Yeah, as well as the children being taken away, a lot, any Aboriginal or Torres Strait Islander who was found practicing their culture would lose all rights to have a job, to provide for their family, and any right to leave an Aboriginal and Torres Strait Islander community. So it really was, you were persecuted and you were prevented from, practicing your culture. You weren't allowed to speak the language. You would lose all rights because you would get a pass to be able to go to, go to town.
Mm-hmm.
So, it was just this really widespread government policy to really strike at the heart of the culture, and to remove so many children, the loss of the parents, but then also the displacement of the children, and how that has, um, really bled into the lives of so many generations. It's still being felt. Yeah.
Mm-hmm.
And it's sad to say it was experienced, all around the world, wasn't it, at that time?
Mm-hmm.
But yeah, it definitely still has an effect. And Australia has some amazing resources on capturing it, and also, where we are in time. I often say, where were other countries 200 years into settlement? We're talking about some of the slums in UK and things like that. So we are building as a nation still. We're still very relatively young, but Aboriginal people and Torres Strait Islander people have kept their culture alive. It's still so very vibrant and so powerful, and it's still to be celebrated. So just, that's what we educate people. Just stop a minute and realize that you have so much to learn in this space. We all
Mm-hmm.
do,
Mm-hmm.
Yep.
Mm-hmm. Thank you for sharing that, because I know it's not easy to talk about. Um, and maybe the flip side of that question is really, and I know, um, I mean, for people who who hear what you're saying, and who are non-Indigenous but want to be allies and do more of the right thing, um, what steps or what advice do you have so that we can heal, so that we can move forward, so that we can have a more culturally safe uh, world and system? I mean, what things need to happen, or what advice do you have for those who want to be a part of doing the right thing? Maybe I will ask Kelly first and then Eliza.
So I think once again it starts with that rapport building. What do I need to know about you? You know, um, this is your journey, and I'm here to um, provide you the options, and you tell me what you want to do about it. And if you need to take time to take this discussion home and think about it, that's fine. We can come back next week. I think these are some of the approaches or to use, and it was one of the things I really liked in the book. Where is it? I've got it right here. Hope for the Plan, and the best and plan for the rest. Having those conversation starters and understanding people are going to maybe hear the medical side of whatever they're facing, their diagnosis, but they're also going to live in hope. And how do we keep that alive and have simple conversations, and maybe more than once, to support people through these conversations. And I've said it before, just displaying Indigenous artwork or wearing it goes a long way, because a racist person wouldn't. If they've got no respect for your culture, they wouldn't be displaying it in their room or on their person. So I think it's very powerful to send a message to Indigenous peoples that you show and respect their culture, and finding out where their family are from. And at the end of my workshops, we share a Padlet, and I have a whole section, and I've called it "Immerse Yourself in Culture." So seek out, cultural events, whether that be a tour or walking some of the trails around, or going to festivals, so you get an understanding and see people in the culture. And then that may be something you may be able to raise in your next rapport building conversation, that, oh yeah, I've been to your country and that's beautiful. That goes a long way for speaking to people's hearts and creating a connection to build upon as you go through a palliative journey with someone.
And what are your thoughts, Eliza?
For me, it's I encourage people to see the individual in front of you. So, forget about, not so much forget, but I mean, be considerate of the cultural considerations, but take the time to connect with that patient or that person, that Aboriginal person in front of you, and learn about their culture. So we have culture within culture. So connect with the person, and take the time to yarn, do the personal before business, connect on that, on that actual level, and then you're able to deliver, that truly culturally safe healthcare, because you're connecting with the individual as opposed to the culture. And once again, being mindful of culture, but let go of any sort of stereotypes or unconscious bias that you're aware, biases that you're aware of, and practice, reflective practice and whatnot when you're yarning with, your patient, because it definitely is. I'm big on letting go of cultural stereotyping. Australia has plenty of that based on the history, and that the media unfortunately have a big role to play within that, and we just need to sort of take a step back and connect with the individual in front of you, by being mindful of the cultural considerations that you've heard, but learn about that person's cultural practices and what it means to take care of those guys in front of you.
Can I ask, what are some of the successes you've had, or the accomplishments you or IPEPA have had that you feel the most proud of?
I fell into palliative care education and training. I have a health worker background, so I've 20 years in Indigenous health now, and I fell into the palliative care project of IPEPA a few years ago, probably 7 years now. I've been in education and training for palliative care, and it was a eye-opener. Coming in, I thought that palliative care was cancer, old fellas, and they didn't have long. So that was my understanding. So when I started to learn more about what actual palliative care is, for me, it was there's a big gap here. In Australia at that time, we weren't putting much emphasis on Indigenous palliative care. It was around, but we go through, in Indigenous health, we go through priorities. Palliative care at the moment is a hot topic, if I can say that, and there's been a definite shift in the last so many years. So for me as a spiritual person, it was just I fell into something that I really enjoy, and that returning to spirit journey, and the concept of having a good death and reframing that for community is just so much beneficial. And then when I think of the flow-on effect from sorry business and someone not having a good experience at the end of life, impacts on that healing and the grieving journey of that individual, and then flows out onto the family, then flows out onto the community. So for me, coming into the space, it's just been, I've so enjoyed it. From IPEPA, I went to Guadalajara National Palliative Care and developed training and education for that program, and now consult on many different, different projects across Australia. And I've just been very privileged to fall into something I'm so interested in. I love the funeral space as well. So, the deaf doulas and that rising. Just quickly on IPEPA, we had a IPEPA Education Week last year with health workers across Queensland. We had 20 health workers view a body being prepared at the funeral home. Now that's for me, that was so heartwarming, because yet we don't talk about it. There's a misunderstanding that mob don't talk about death and dying. Yes, we don't generally, but there are those in the community that have a genuine interest and want to care for their own, in that sense. So once again, that's, where we're culturally stereotyping. Our communities miss out on having yarns around, palliative care events, care yarning, or, organ donation, those sort of things, because the misconceptions there that we don't want to talk about death and dying. And generally we don't, but there are those that are willing to have those yarns. So for me, coming in, I've got, I'm, we're humble peoples as well, but I'm quite proud, of coming into the space and just making, reframing that returning to spirit journey for those that get it. Because when we reframe it for community, for health workers, they definitely get it. It's just bringing in that cultural context. And when we're yarning, putting that, that's what we do as health workers as well, bringing the Western world together with our world, and just making it make sense and putting in a context in that sense. So I've got many accomplishments that I'm proud of, but and I probably should say my number one, though, is my children. Always will be my greatest achievement in this lifetime. Yeah.
Thank you.
Mm.
And Kelly? Yeah.
Yeah, so I've now been, I guess, on my palliative journey, working in this space for 3 years, coming up to 3 years. So it's just been amazing to find the goodwill amongst the workforce, I think, and policy. But what I find most rewarding is sitting down with people and talking about some of the things they've experienced, and the learning together about, some of the science, but also some of the approaches and the social and cultural safe aspects. But I guess some of the outcomes have been that we have a neonatal bereavement guideline in the hospital I work in, and that came out of a workshop with Aboriginal interpreters sharing, a lot of the ins and outs of their culture, so that we can build that into, place where it's safe for families to meet. That the hospice is a is a culturally safe spot where families will be accommodated and may most probably will be a lot more comfortable to go through this journey of, that no one wants to face. And everyone's invested when, babies and children are involved. And another one is Purple House, who are renal service deliveries, conduct renal services in Central Australia and in Darwin, and have community connections. There's a project called the Last Look Project in Central Australia, where Purple House have got some money to be able to return people home to visit their families to pass away, or just to visit and then to return to the hospice. And that's just so very powerful. And it hasn't existed before because, there's so much area to cover, so many different land types in the Northern Territory. We are islands, wetlands, desert, and savanna. We have all these seasons where communities are closed off and there are not very many morgues. So just sitting down and having those discussions, and always learning, I think is so very rewarding, and people really get it, and they're so very thankful and grateful at the end of it. Um, yeah,
Yeah.
just by also using some of the resources that were created before me, but some people haven't really thought about, because palliative care is, this 20% of healthcare. I seem to think, most of it's all about healing and curing. And so just spending that time on palliative care and how it does differ, and it is much more nursing care, and much more family oriented, I think is very, very powerful.
I have one more question, but before I ask it, is there anything that you both want, is there anything that you wanted to talk about or wanted me to ask that I hadn't yet brought up?
Yeah, I guess attending my first Oceanic Palliative Care Conference last year was very eye-opening, and particularly amongst Indigenous peoples around the world. The impact um, of kidney disease and diabetes. You really, those countries such as Samoa and the Pacific Islands, and we heard from Malaysia, and they are creating, there is a need for better palliative care services, and to create a nation's first palliative care service. And I just think there's so much work that needs to be done, and support that could be provided to these different areas and learnings together. I think that's just not happening at the moment. I guess what I'm saying is, a lot of the palliative services setups are created using the UK method and Canadian methods, and that. So people don't necessarily want services, introduced and they have to get on board. They want to sit down and plan the programs and the services based on how their culture and their countries work. And I just thought that was a really exciting way to approach it.
Yes. Eliza,
Yeah.
is there anything that you wanted to mention or bring up that I didn't ask about?
There's probably two things, but if I can just elaborate on what
Yeah.
Kelly's yarning about. So I think there's an opportunity for us in Australia as well to learn from Canada and the States in terms of the Aboriginal people are our closest cousins in terms of cultural and history. So cultural perspectives and history, there's so much similarities there that there's an opportunity for us to learn from what's happening. And if you guys are advanced in terms of connecting with community, engaging and successfully palliating patients at home, I think there's an opportunity there to learn. There's also the element of advanced care yarning. I was wondering what that looks like and how it's navigated. We in the research projects and the communities navigate advanced care yarning, which is advanced care planning, but we interpret that to yarning because it's a yarning conversation where people have an opportunity to share their wishes. How is that being navigated when there's a reluctance to talk about death and dying, to plan ahead? So there's curiosities there that I'd love to explore as well. But as Kelly said, there's definitely opportunities for all of us to work together. But as Kelly said, if I go back a step as well, it's all about co-designing for us here in Australia, because there's a history of here you go, you mob, we've made this for you, you go run it. And then, government and white society wonder why it never works. It's because we've never had any involvement in actual developing something. So we now have a saying that says nothing without us, nothing for us without us. So there's a big push on, co-designing and, connecting with community and our programs coming from grassroots. So once all of those things come about, hopefully we'll have something, a model that we can sort of run with.
But there's a lot of challenges that we face. This is hard work. What brings you hope?
Hope. I guess we have so many exciting things coming up. Um, and I just love um, contributing to people having more power and being able to make informed choices. So I'm really excited to get to some new communities. I spoke to you about that earlier, about going to Uluru or Ayers Rock for the first time and walking through those communities. And just every time I engage, I learn and I get better at it. Um, so yeah, that's what brings me hope. And I just absolutely love this area of work. It's so very rewarding. And knowing that it's contributing to people's care so directly. And I find the health workforce that I engage with on palliative care appreciate the time and are open to the learning. So it's very rewarding, even though it's possibly the most nerve-wracking thing to sit down with a group and talk. It's a bit contrary to human nature, but yeah, that's what I really enjoy.
And how about you, Eliza? What brings you hope? What keeps you hopeful in these times?
Personally or professionally?
Either, either one.
Personally, I think universal connection and empathy and understanding, especially in the times of where we're at in terms of countries conflicting and the impact that has on the rest of the world. Phantom and AI technology, all those scary things that can impact on all of us. I think coming together universally, that's on a wider scale. But I think professionally, for me, in the space that I'm in, um, having fulfilled wishes, whatever that looks like in terms of when someone's on that return to spirit journey, and for me, that does not continue when the person's passed. It's all around the funeral planning and supporting families through that grieving process. And unfortunately, on the other end, if our wishes aren't heard in terms of advanced care planning, and you bring in those sort of elements, whether it's palliative or unexpected passing, it can halt it can interfere with the grieving and healing journey. And if someone has a good death, palliative, then it impacts. If somebody has we all know, the unexpected passing, it impacts on that. But if we're not sharing our wishes in any way, shape, or form, and even if it's simply as burial or cremation, or where someone wants to be on country, off country, those things impact on families in their long-term healing journey. And spirit on a spiritual, my belief is that the spirit's not resting if our family are all, in conflict over, different elements of the planning, or are not grieving in a way that is, that's complicated grief in a sense. So spirit's going to be here supporting us. It's not going to be on the journey we're making its way where we believe that the spirit goes. So it's those elements for me personally. I think if we can get to a place where we can share our wishes, and I always say to people, it's not about running around telling everyone. Just tell one or two people that you're comfortable with, or just write it down and put it somewhere. So when the time comes, at least someone can say, or go grab it. Like, if something happens to me tomorrow unexpectedly, go grab that purple folder and my wishes will be there. So professionally, that's what I hope for. And obviously that impacts personally, because we're emotionally attached to the work we do, because we're supporting our own communities and the people we love.
Thank you both so much for joining us today. I learned so much.
Thank you.
Thank you.
Yeah, it's been awesome.
Hey, thanks for listening. Don't forget to rate, review, and subscribe if you haven't already. Visit our website, waitingroomrevolution.com, for more information, to join our newsletter, and to check out our book, Hope for the Best, Plan for the Rest. This podcast is produced by myself, Kayla McMillan, Shilpa Jyothi Kumar, and Maggie Sivek, and our theme music is Maypole by Ketsa.